Everybody. Good morning, good afternoon, good evening, happy Wednesday or happy Thursday, depending on where you're joining from. It is great to see so many familiar names and some new names today. My name is Jack, for those of you who I haven't had a chance to meet yet in the VMR space or another space. And I'm just super pumped to see everybody here for what is bound to be an incredible case today. Gurleen is going to be presenting a case, and the pretest probability of a brilliant discussion or of a brilliant case, a really challenging diagnosis is very high, and then the quality of the discussion is going to be up to us. But before we get started, I would just love to know: is there anybody who's here today for who it is your first VMR that you've ever been to? Feel free to raise your hand or type it in the chat. Oh, Jamil, thank you so much for being here. It is very exciting. Jamil, if you're in an okay spot to unmute yourself, would you mind introducing yourself and sharing where you're joining from? And it's totally okay if you're not in a good spot to talk. All right. Well, regardless, Jamil, welcome from India. It's great to have you here. And I'm curious, what are you a student, a resident, and attending? Where are you in your medical journey? 12:30 at night. I can imagine it would be hard to talk. Well, thank you for the dedication to clinical reasoning and clinical problem solving. That is just awesome. We are going to go ahead and get started. Oh, awesome. Consultant physician. And what is your consulting specialty? There we go. Internal medicine. Well, Jamil, thank you again for being here. Welcome to the VMR family. I tell everybody who comes once that you're sort of stuck with us forever. Hopefully, we will see you at many virtual morning reports to come, but I'm just so happy that you're here today. For those of you who may have not been to one of these Wednesday VMR sessions recently, we have like a little bit of a different format than the traditional two people discussing the case with two facilitators. We're going to sort of make this one big team effort today. Clinical reasoning is a team sport, and as is, it is very rare that we ever work through a case on our own. And so I would love to have as many possible people contribute to the discussion today, whether that's typing things out in the chat or unmuting to share your reasoning out loud. Would really want to just hear as many people sharing their reasoning out loud as we work through Gurleen's case together. And so please do liberally share your thought process in terms of what's happening for you as you reason through the case. And I may call on you to ask you to share your reasoning more out loud so that the people who watch this after the fact on YouTube have an opportunity to hear your clinical reasoning. The other thing that we want to focus on is not just what we're thinking, but why we're thinking it. So rather than just sharing a single diagnosis that you think it could be, really focusing on showing our work and showing our reasoning process. And so as we talk through the different aliquots of the case, we want to not only talk about what we're thinking, but why we're thinking it, so that we can refine our reasoning process. And with that in mind, I'm going to go ahead and we'll let Rafa take over the screen, and then we'll turn it over to you, Gurleen, to first introduce yourself, and then we can go ahead and get started with the case.
Thank you, Jack. I'm so excited to be here and see some familiar faces and some new faces. So I'm Gurleen. I'm an internal medicine intern at Brigham and Women's in Boston. I'm excited to learn from today's discussion from everyone. So this case, I can get started. I think I see the whiteboard. So this is a 58-year-old female who's presenting with acute altered mental status. She was reportedly at a friend's house and had progressive confusion and somnolence there. There was no report of any ingestions, no witness seizures, and no other precipitating events that we knew of. Per some brief discussion in the emergency department with the patient's daughter, the patient was in normal mental status earlier that day, and there was no other reports of trauma. And that's the first aliquot.
All right, so it seemed like we have, and just just to clarify, what exactly were the time course of these changes?
So it was pretty acute. Like she was at a friend's house, was doing fine, and then over the couple hours, days, like a half day, she had progressive confusion and somnolence.
Yeah.
Kind of unclear story when she first came in. It was just that earlier in the day, her daughter said she was fine. She was
Okay.
at a friend's house, and then she became progressively confused and somnolence during that half day period.
Amazing. Well, I thank you so much, Curly. This is always a very interesting start when we kick things off here. And actually, before even sharing anything about what I'm thinking, I'm gonna kick it over to those of you in the chat who are already sort of on the scent of how we're gonna think through this. Deborah, I noticed that you mentioned MIST here, and I would just love to hear your thought process in terms of how you're thinking about the approach to altered mental status overall, and then specifically in this patient, in this 58-year-old woman.
Yeah, I said the MIST, MIST, that means metabolic, infection is structural and toxin. And we can think all this for causes. And besides that, we can think, I always think about deficiency of vitamin B12, or I don't know, like urinary retention, constipation, like in the CNS, we can think of meningitis, encephalitis. Yeah, a lot of things come in my mind, so I think we need more information.
I could not have said it better myself. It can be really challenging to move through and really make progress when we have only defining of altered mental status, right? The time course can sometimes be helpful. For example, if it was acute to the point that it's actually hyperacute, where it happens like instantaneously over seconds to minutes, that may move us more towards something like a structural problem related to the vasculature, or a structural problem that could be related to something like a seizure episode. But it seems like we're sort of in the like hours to day time range. And honestly, I have a lot of, I really struggle to reason effectively through that initial altered mental status approach when we're over that time course without some of the data that you mentioned needing, Deborah. Are there accompanying infectious symptoms? What do we know about the underlying metabolic abnormalities, or even risk of a metabolic abnormality? Is there a history of CKD or liver disease or underlying diabetes? And then also without some sense of a toxin history. So as usual with Gerlene's cases, more questions than answers to start off, but I'm super excited to see where this goes.
Yeah, so in terms of past medical history, she has a history of hypertension, hyperlipidemia, type 2 diabetes, recurrent depression complicated by psychosis in the past, and anxiety. In terms of home meds, she's on amlodipine, lisinopril, metformin, Trulicity, atorvastatin, aspirin, hydroxyzine, and risperidone. Initially don't have any more information about other things like social history. On talking with the initial conversation with the daughter in terms of what information the ED had, it was just known that she was doing fine, no recent like systemic symptoms. Complete review systems wasn't really able to be obtained. And then I'll give the initial physical exam as well. So her blood pressure was 170 over 116. Heart rate was 120. She was afebrile. Respiratory rate 34. Initially satting 95% on room air. On exam, she was very somnolent, wasn't able to follow commands, had few small respirations, withdrew to painful stimuli, but otherwise very somnolent. HENT normocephalic. She had some leaves found in her hair in the ED exam. No spiral icterus or injection. Her pupils were equal, round, and reactive, non-pinpoint. Her oropharynx had some scant dried blood. For cardiovascular exam, she was tachycardic, otherwise no murmurs were heard. Respiratory, she had increased work of breathing with prominent small respirations, really deep and rapid breathing pattern. Abdominal exam was soft, non-tender, non-distended. Trace lower extremity edema with no tenderness on the lower extremities. For neuro exam, she was not alert and oriented, only opens eyes with painful stimuli and grimaces with painful stimuli. Otherwise, other part of the neuro exam was difficult to obtain at that point. And that's the information for the physical exam. Sorry if I read it too fast.
Amazing, Doreen. While we let the physical exam make its way on the onto the board, I'm going to actually say that for like practicing our own reasoning, we're going to break up this aliquot in terms of how we discuss it into two parts. The first part is going to be just looking at the past medical history that we have. What are the things that you all notice in terms of the past medical history and the medications that she's on? And how are those things influencing the way you're thinking about the initial approach to altered mental status that Deborah gave us, right? So like what are things you're noticing in the past medical history that are influencing the way that you're thinking about her altered mental status? Ooh, I see Carolyn bringing up a great question here. Carolyn, do you mind unmuting and sharing a little bit more in terms of sort of linking the risperidone to the altered mental status?
Yeah, sure. So I'm not sure why it's not blue, but I think it's on her medication list, right? So just thinking about kind of seeing those vitals, the vital signs, kind of the tachycardia and her high blood pressure, along with the altered mental status, makes me worry about neuroleptic malignant syndrome.
Awesome, right? So again, so sort of going through this reasoning exercise of saying what is the background information in terms of the medication that she's on, and how can that inform the foreground information, right? And neuroleptic malignant syndrome is one of those diagnoses that can be difficult to at least manage effectively if we don't specifically think about it, right? For some disease processes, right, if somebody has a fever and they get antibiotics, we don't necessarily have to know where the infection is, but if they get antibiotics, it may help. Whereas the treatment of NMS is quite an uncommon medication for us to use. And so, right, bringing that into the fold based off of the risk factor of the presence of risperidone is going to be a helpful thing so to help us avoid missing the diagnosis here. And then I see, I saw somebody who was mentioning the possibility of a lactic acidosis and the metformin here. I think Motaz was bringing that up. Motaz, do you mind unmuting and sharing a little bit more?
Good evening, everybody. Thank you for allowing me such opportunity. And I am suggesting only this lactic acidosis being on background of being a diabetic using such metformin that has a possibility of causing lactic acidosis. Also on the background of being depression, maybe some sort of antipsychotic medication induced hyponatremia. Maybe if the lab chemistry has shown some sort of hyponatremia, maybe a cause of altered mental status that can be suspected in such case.
Motaz, I think that reasoning is absolutely phenomenal, and also for those of us who haven't had a chance to meet you yet, which includes myself, I'd love to know where you're joining us from today and know a little bit more about you.
I am a nephrologist working in some OBD of nephrology, having only follow-up for outpatient cases of some renal patients.
Well, then I cannot think of a more fitting person to mention the possibility of a metabolic acidosis in this case. Thank you so much.
Thank you very much.
And so I think like where I'm hearing the group going in terms of thinking about the background information here is really right moving from the general categories to starting to think about specific diagnoses, right? In the metabolic column, we see the presence of diabetes that makes us wonder, well, gosh, is there potentially an underlying glycemic issue causing altered mental status, right? Both hypoglycemia and hyperglycemia can give us altered mental status, but the pattern of that altered mental status may be different. Hypoglycemia is oftentimes transient unless the patient loses consciousness, right? So like somebody may have a transient hypoglycemia episode, and then once the glucose raises, their symptoms resolve, whereas hyperglycemic problems tend to be more persistent and last for sometimes hours, days, or even longer, right? If we go into the physical exam here, I see some people mentioning the possibility of how we could link the diabetes to some of the physical exam findings. So I'm going to save that there, right? But for the metabolic category, we have multiple hypotheses to explore. Is there a glycemic problem, or is this potentially related to a consequence of the medications we're giving for the glycemic problem, as Motaz mentioned with the metabolic acidosis from the metformin, right? Infections are certainly on the DDX here, right? We don't necessarily have any localizing syndrome here, but Deborah brought up the point of thinking about meningitis, encephalitis, or non-CNS possibilities. And given the morbidity of that, right, we can't necessarily take that off of our list until we've effectively falsified that hypothesis, which is going to require looking more closely at the exam and the labs. Structural problems are certainly potentially there. I saw Hans mention it in the chat, a potential vascular compromise. And then toxins, right? We learned the importance of bringing toxins into the fold from Carolyn, whether that's a medication that she's already prescribed, and thinking about the neurologic complications of these centrally acting agents like risperidone, or right, if or potentially thinking about a toxin that the patient may not be prescribed, but potentially may have been exposed to, right? And so we can see how we can sort of manipulate the data in the background of this patient for the past medical and the meds to really inform how we're thinking about the altered mental status that we have up front. And then Hans, I see you mentioning the potential of the Kussmaul respirations. Do you mind sharing a little bit more sort of about how you're integrating the Kussmaul respirations here? Hans, are you able to unmute?
I got distracted.
Oh, no
I
worries.
have to ask to repeat the question again.
Oh yeah, you mentioned the possibility of Kussmaul respirations here, and sort of how that and what some of the diagnoses that was making you think of were. So I'm curious if you would if you'd be able to share a little bit more.
That was mentioned by somebody else, the Kussmaul respiration, and I was thinking about a metabolic derangement such as a metabolic acidosis secondary to ketoacidosis, lactic acidosis from metformin, and so on.
Awesome. Thank you so much, Hans. And then AMK bringing up a brilliant reasoning point here. Anne-Marie, do you mind unmuting and just sharing that in terms of sort of how you're framing which of the glycemic problems is more likely here?
Yeah, I was just looking at thinking about which medications are more associated with hypoglycemia, which is generally insulin, and then sulfonylureas, which aid insulin release. Some of the other medications with those meds can be associated with hypoglycemia, but metformin should not cause hypoglycemia. And then a GLP, I think she was on Trulicity, I believe, alone should not cause hypoglycemia usually.
Amazing. I love it. I love it, Anne-Marie. Thank you so much. So it seems like where we're at now, just to sort of hear from the group, we're wondering about a metabolic possibility. We have potential hypotheses to explore within the toxin area, but really everything is still potentially on the differential until we see some of these labs and hopefully some head imaging to guide us further, acknowledging that wherever our diagnostic momentum is taking us could totally change depending on the labs that we see here. So Gerline, I'm going to kick it back to you to take us through whatever you have in store next.
Yeah, so she was given Narcan without any change in her mental status, and her finger stick blood glucose was 263. And then in terms of her other lab data, her white blood cell count was 18, 81% neutrophils, 12.6% lymphs, 5% monos. Hemoglobin was 13, hematocrit 44, platelets 346. Her sodium was 138, potassium 5.3. Chloride 99, bicarb 7, BUN 20, creatinine 1.32, glucose 278, calcium 10.3, mag was normal, albumin 4.5, total protein 8.9, ALT/AST were hemolyzed, it was a hemolyzed sample, alk-phos was 121, Billy was normal, her ABG was 7.22, 12, and 143. So pH 7.22, CO2 12, and O2 143. Lactate was 10.2. Beta hydroxybutyrate was 0.7. And then just some other lab work. Her UA showed 2+ glucose and trace ketones. Otherwise was normal. Her Tylenol level was below assay. Ethanol was negative. Salicylates and urine tox was negative as well. The urine tox includes amphetamines, benzo, cocaine, fentanyl, opioids, cannabinoids, which were all negative. And then she was negative for COVID, and upper respiratory viral panel was also negative. Her carbon monoxide level was also less than 0.6, and her CPK was 130. Then I just have some like basic imaging as well. Her chest X-ray was normal, no consolidations, no edema, no abnormalities. Her CT scan, she got a pan CT, no abnormalities in the CT head or CT spine or CT chest or CT abdomen and pelvis.
All right, a wall of excellent data from Gerline here yet again. The chat is just absolutely blowing up here. So let me just take a quick scan here to see what some individuals are thinking, and see kind of where we can potentially go next. I see that the great Rebecca Berger is here with us. Rebecca, it is wonderful to have you here. Would you mind, I see you throwing out tons and tons of pearls in the chat. Would you mind unmuting and sharing a little bit more about sort of what you're noticing here in terms of thinking about the risk of DKA and the lactic acidosis and all that?
Hey everyone. Yeah, so the comments I made, I think most people are probably aware, obviously, that type 2 diabetes is much less commonly associated with DKA than type 1. That being said, there are definitely patients with advanced type 2 diabetes and have kind of a more type 1 phenotype. There's also patients who are diagnosed with type 2 that probably actually have more of a type 1.5 or LADA kind of autoimmune phenotype, and sometimes that's misdiagnosed or underdiagnosed. And then also some patients with type 2, even if they're normally pretty insulin resistant, and don't have that kind of low insulin state, can still have other things that can trigger DKA, severe infections, other adrenergic surges, exposure to steroids, et cetera. And then the other thing, originally when I saw that bicarb of 7 and the pH of 722, I think all of us started thinking about DKA because we had talked about it before. But with that lactate of 10, I think we obviously have to explain that as well. That shouldn't, DKA can cause severe hypovolemia, if you've had nausea and vomiting, which can cause an elevated serum lactate. But I kind of feel like we need to explain that lactic acidosis first. We would want to, I do now see measured ketones. Beta hydroxybutyrate, I don't know what the reference range is there. I don't know if that's elevated or not, but looks like this might be definitely lactic acidosis, possibly a ketoacidosis on top of that. But I think the lactate could be enough to explain, much of the acidosis that we're seeing. So I'd want to try to understand whether she's had some type of ischemic injury to her gut or something else to cause, that degree of lactate elevation, whether she could have had a seizure, which also could have caused that degree of lactate elevation. Those are kind of the things that come to mind with lactate elevations that high. Usually we don't see the lactate of 10 if somebody's just hypovolemic. Usually that's either a seizure or, or more kind of ischemic injury somewhere, the gut being common.
Ooh, absolutely phenomenal. Thank you so much for sharing that, Rebecca. I too missed that the beta hydroxybutyrate was 0.7. So thank you for flagging that for me as well as we continue to think through this. And it seems like from Gerline, yeah, like so just slightly above the upper edge of normal. And then kind of just scanning through some of the other pieces of information here. I see a couple people highlighting the fact that there's a leukocytosis here on the lab findings. And I think we sort of have two things to sort of question here. Is the center of gravity of this case going to be what's driving the lactic acidosis, or is the lactic acidosis a bystander finding in the setting of some other severe disease process that we haven't yet found that is just contributing to the elevated lactate level, right? Like we have mentioned the possibility of something like a metformin associated lactic acidosis, and in a case like that, right, the elevated lactate level is really going to be the center of gravity of our cognitive functioning. And rather, if we have something like a severe underlying systemic infection that's driving the lactate level, right, then the white count of 18 is probably going to be the thing that's driving us here. And so I think in terms of like where we invest our cognitive energy, I think we sort of have to ask ourselves the question of what seems more likely. Is it more likely that the white count is being driven by the underlying metabolic acidosis, or is it that the metabolic acidosis is being driven by whatever is potentially driving the white count? Or is there a third possibility, right? Do we have some sort of underlying severe systemic infection that has tipped the patient into developing metformin associated lactic acidosis? I will say that, right, like if we just to talk briefly about the finding of lactic acidosis in somebody on metformin, there are many patients out there who take metformin for their underlying diagnosis of diabetes, but the vast minority of them go on to develop severe significant lactic acidosis. And so what are then the risk factors of metformin associated lactic acidosis? And usually it's something, it's either it's a problem in one of the organs that helps us process medication, so underlying chronic kidney disease, underlying liver disease, or an acute injury in either one of those organs. And so I would be curious in this case, right, like is this creatinine of, I think it was 1.3, right? That doesn't seem terribly high. So it doesn't seem like we're dealing with a significantly compromised renal function here that could be the driver of a potential consequence of metformin. But is it potentially the systemic infection that may or may not be there enough to tip us over into developing a lactic acidosis? It's also important to recognize, right, that like while we are mentioning a metformin-associated lactic acidosis, there's a ton of things that can do it overall. And I see that, I think it was Anne Marie who dropped the CP solver schema in the chat about it, but really like the sort of main branch point when we see the lactate level like this is this a type A lactic acidosis, which is going to be related to underlying hypoperfusion, cellular hypoxia, or a high metabolic demand? Or are we dealing with a type B lactic acidosis, which is usually due to problems related to gluconeogenesis, like we see in liver disease, disruptions in cellular metabolism, which can happen with toxins or certain medications? Or is it related to the ingestion of an endogenous substance like propylene glycol, or is it related to very, very high glycolysis, which is a rare thing that we see in something like underlying cancers via something called the Warburg effect? And so in this case, I think like the jury is really still out in terms of whether or not we're dealing with a type A or a type B lactic acidosis. I will say oftentimes if we have a lactic acidosis coming from underlying hypoperfusion, like in the setting of septic shock or distributive shock, we would expect the patient to be hypotensive rather than hypertensive like we have here. There is the possibility of something called normotensive cardiogenic shock, but we would expect to see the physical exam findings suggestive of decompensated heart failure if that were the case, right? We would see things like elevated jugular veins, crackles, or lower extremity edema. There was also the possibility, right, of rather than it being diffuse systemic hypoperfusion, a focal systemic hypoperfusion, like in the case of mesenteric ischemia, which I saw a couple of people mention. And I think that one, right, is certainly a sinister diagnosis that we can very easily miss. Patients oftentimes will have abdominal pain, but there's a possibility that our patient's somnolence is limiting our ability to understand whether or not there's pain there. And the benign belly exam doesn't significantly decrease the probability of that because, again, mesenteric ischemia is usually pain out of proportion to the exam that we may find, right? And so I think where we're at now is we sort of have two diagnostic hypotheses to work forward. Is one, I think we have to explore the possibility of whether or not there is an underlying systemic infection that is driving the white count and potentially a contributor to the underlying lactic acidosis. So I think that that's one route. The second route is going to be, is there possibly focal organ hypoperfusion that's happening that's driving the lactate in the setting of there being this, in the absence of the systemic hypotension? And then the third pathway that we're going to have to explore is there actually not a perfusion-related cause of metabolic acidosis, but rather is there a metabolism cause of the very, very large lactic acidosis? And that's going to be sort of exploring the possibility of things like metformin, propylene glycols, or potentially an underlying malignancy that we haven't yet discovered yet that's going through very, very high glycolysis. But I think like practically how we would reason through this is we would consider the possibility of infection and sort of go through any remaining infectious sources that we haven't explored yet, right? It seems like the CT chest, abdomen, and pelvis are all negative, but is this somebody in who we might need to get a lumbar puncture to further explore more? So I think that that's one route. We're going to make sure that we don't see any signs of underlying mesenteric ischemia on the CT scan. And if both of those routes turn up negative, right, the sort of infection route or the focal organ hypoperfusion route, then I think we have to shift our cognitive energy and start to explore this other world, which is the sort of not necessarily perfusion, but again, metabolism related lactic acidosis, and ask ourselves, could this be related to the metformin? Was there recently a high ingestion of metformin that could be driving the lactic acidosis, or is there another exogenous toxin that we don't that we haven't necessarily identified yet because we haven't gone looking for it yet? So I think that I'm very curious to see where your team took the case, Anne-Marie, but I think that sort of is how I would prioritize things of like infection, focal organ hypoperfusion, and then if both of those turn up unrevealing, then we pivot over into thinking about whether or not the metformin or some other toxin is driving this.
Great discussion. The chat has been asking great questions as well. So yeah, to clarify, the CK was 130. So in the next aliquot, so obviously she was very sick. She was transferred to the MICU. At one point in her transfer, at some point in the ED, she did wake up and admit to taking pills at one point, but it was still very altered, kind of unclear when this when the team found out that she had possibly taken some pills. And then more collateral was obtained from the daughter when she was in the MICU, and the daughter mentioned that her mood had been getting worse in the past 2 months with stress at work and recent death in her family. And she seemed to not be herself in terms of her mood or her ability to kind of do things. And she seemed to be a little off and feel a little confused and couldn't keep things straight the past couple of weeks. She noticed that her mom had been shivering at times, acting odd, especially in the last 2 weeks. And at one point, the patient had mentioned to her daughter that she'd be better off dead, but she denied any she hadn't told her daughter that there was any active plans to harm herself. In terms of kind of just some progression, her pH worsened to 7.16. I know Anne-Marie had asked about the delta for the lactate. So around 3 hours after the original lactate, her lactate was up to around 12.4. So she initially received a bicarb drip as a temporary measure, although it doesn't like help with the lactate or the underlying physiology just because of that low pH. And then she became hypertensive to 250 over 109, was started on a labetalol and was getting an nicardipine drip later as well. Initially, I know the chat was talking about in terms of respiratory support. So initially, her tachypnea she was compensating herself because of the large tidal volumes that she was pushing. So initially, we didn't want to intubate because that could actually hurt her because it would be harder for the vent to match her native like respiratory compensation. But ultimately, because of airway protection and worsening mental status, she was intubated. And she was also then started on CRRT for clearance of toxins with the concern that since she had admitted to ingesting some pills, that this was something from her medications that was causing it. I have one more aliquot after this, and then I'll reveal the diagnosis.
Amazing. Thank you so much, Carleen. So I guess just to sort of take a second to sort of digest this all for myself. Seems like we have some concern for an underlying ingestion that could be driving this, but we're not exactly sure what the underlying ingestion exactly is. And then certainly there is this very, very terrifying worsening clinical decompensation in terms of the worsening metabolic acidosis, but then also the worsening respiratory compromise. I see that Ravi is with us again today, and after a brilliant discussion yesterday, is sort of pointing out something that to be honest, I had missed in thinking through this case already, which was how potentially the patient's aspirin could be driving all of these, both metabolic and respiratory abnormalities that we see here. Ravi, do you mind if you're in a place to unmute and share a little bit more, teaching us about what you're thinking here?
Hey, Jack, you're doing a fantastic breakdown of this case. I'm just in all the teaching points that you're given. But I also want to shout out to Rebecca. She actually also mentioned, I was looking at the list of meds, and they're awfully suspect, just like people had mentioned metformin, maybe lisinopril antagonizing the kidney failure and so on. But yeah, definitely metformin sticks out. But aspirin can be a great thought in this, especially that when Gorlene's mentioned this patient's not been acting well, may have tried to end her life. So this is an easily accessible medication that she may have tried to take in excess. And this does fit the acid-base disturbance here. Rebecca had mentioned that the patient has metabolic acidosis. That can be an AGMA, HAGMA plus a simultaneous respiratory alkalosis. So this definitely does fit in, and I think it's still in the running as a differential. What do you think, Jack?
I have nothing to add. I think it absolutely is possibly here. And then I see Anne Marie mentioning the point of this. There is sort of this like this hyperadrenergic drive happening with sort of the worsening hypertension and things like that. AMK, I'm curious if you have any thoughts in terms of like how you break down this sort of finding, or if there's any potential culprit in from medlist that could be driving this.
Yeah, so some of the things that I think about, there's tachycardia, there's this like severe hypertension. So something is driving it. And I always think about, is this endogenous or is this something exogenous that was taken? Or is this a combination of both at play? Here, kind of with the time course and the ingestions, I'd be thinking about more exogenous things. So thinking about, could this be a withdrawal state, either from alcohol or benzodiazepine, or kind of other substances, or could this be something like a serotonin syndrome, or some other substance that is inducing this, like cocaine, like other ingestions that could be contributing and maybe even causing like a Press syndrome or non-convulsive seizures or something like that. So I definitely be trying to find that, and also thinking about the thyroid as well.
Amazing. I would say I have nothing to add to the conversation that has been shared so far, but I think like now we have sort of moved or are sort of moving towards this ingestion category of things, and whether that's related to sort of I should say the ingestion category driving the underlying lactic acidosis, whether that's related to a hyperadrenergic state or some sort of ingestion that we haven't found yet. The good news is that for at least some of these, we have fairly quick and fairly accessible tests that we can do. So as Rebecca and Robbie said, an aspirin level should come back fairly quickly. An alcohol level, if there is alcohol on board, although that seems unlikely given that we have more of a withdrawal syndrome, right? The alcohol level could come back. A Tylenol level could come back quite quickly. And so there's a chance that one of those gives us the answer. And there's also the, I think, very reasonable probability that there's actually multiple factors driving this, right? We could have the combination of the presence of metformin, the aspirin, and potentially other medications that could be driving this, but certainly it's quite concerning that there was a known history of an ingestion and this known history of what sounds like suicidal ideation. So I think the other thing practically that I at least I know I would be doing taking care of this patient is basically calling toxicology and getting them on the line and see if they recognize any sort of compatible clinical toxicrome here. But I think that sort of is where I could see the testing take us. And then it sounds like there's some more information that we get from Gerline before the final diagnosis is revealed. So I'm excited to see what that is.
Yeah, so some just additional labs that we added on in the NICU. Her measured serum osmolality was 318. And if you calculated from her BMP, her calculated was 302. And then during the progression of her labs, her creatinine worsened pretty rapidly to 2.27 and GFR was 24 at that time. And her volatile alcohol panel was negative. This is the rest of the information before the final diagnosis.
We have an OSM gap of 16, and then the volatile alcohol panel is negative.
Yes.
You know, I would say I am my ability to reason forward beyond this level without having to look things up is actually incredibly limited. And so I know that we have some nephrology experts on the call here who may be able to take us through this. But I'm really curious from the team sort of how you all are integrating this data so far. Yeah, I would say I am right there with Kishal and Alec mentioning things in the chat, right? And an OSM gap I usually associate with toxic alcohols or the underlying lactic acidosis. I don't know if her lactate level can explain the OSM gap that we have here, but I think it's in the absence of toxic alcohols. I feel like it's reasonable to explore the other hypotheses that we had considered, which included things like salicylate toxicity or underlying metformin toxicity. Xavier, do you mind sharing a little bit more here? I imagine that as a nephrologist, you're much more familiar with these cases, certainly than I am.
Yeah, thank you. No, these cases are very challenging because at the beginning, everything is on the table from a diagnostic perspective. The good thing about this is that hemodialysis is effective at treating many of these disorders. So, somebody mentioned about getting a metformin level. Unfortunately, metformin is typically a send out lab, so you will not get a level right away. You gotta act upon the clinical suspicion, and if it's very unlikely to have a really high osmolar gap with a negative volatile alcohol panel. I mean, typically, if a person has had a toxic ingestion significant enough to bring her to this clinical presentation, you should really expect to see some degree of level of the alcohols in the blood. You can check a UA and search for oxalate crystals, but those are only surrogates. So typically, the patients will present with slurred speech, features of being inebriated, and then with profound ultimate status. So with that in mind, I think I will put the first metformin toxicity as my first and most worrisome complication, and then my next clinical suspicion could be salicylate and maybe lower the toxic alcohols.
Amazing. Thank you so much, Xavier. That is really, really helpful to get to learn that from you. And I think it makes a ton of sense to hear the ways in which you're reasoning through this. I will not pretend to be able to add anything to your discussion there. And so I'm curious, Praveen, where did your team settle on this? And would love to hear from you kind of some of the teaching points you learned from what I can imagine was a really rich and hopefully a good outcome for this patient overall.
Yeah, definitely. We were as confused about the different labs that we're mentioning. So we did get toxicology on board as well, as Jack mentioned. They're a helpful team to help guide us through this case specifically. And so final diagnosis. So in talking more with her daughter, there was some concern for antifreeze ingestion. She said that her mom had watched like a commercial of antifreeze recently and was kind of unsure if this could be related. And then ultimately what also helped with the final diagnosis was the ethylene glycol level came back as 478. So I think a major teaching point for me was I didn't realize that when we said, oh, volatile alcohol panel is negative, I didn't realize what that includes. So that only includes, at least in the one that we had sent off, only includes methanol, ethanol, acetone, and isopropranolol, and does not include ethylene glycol. So she was given fomepizole for the ethylene glycol toxicity. The other teaching point, I think, is that why was there this big lactic acidosis? So I think the final diagnosis was there's some component of ethylene glycol poisoning as well as ingestion of metformin. But what was a really interesting point that I had no idea about was that you can see false elevations in lactate in patients with ethylene glycol poisoning because the lab instruments can't differentiate between lactate and glycolate because of structural similarity. And glycolic acid and glycolate are the byproducts of ethylene glycol metabolism. So what happens is that the glycolic acid cross-reacts with lactate oxidase that's used in the blood gas analyzers in the electrodes that measure in the lab the lactate level. So it can lead to false elevation of blood lactate. So I think these were like the main 2 points that were really important that I learned. And I think just going over in general, when we think about ethylene glycol, it's absorbed in the GI tract after ingestion, then it's metabolized in the liver using alcohol dehydrogenase. And that's the enzyme that metabolizes it to glycolic acid and glycolate, and then eventually oxalic acid. And fomepizole, where it works is that it inhibits the alcohol dehydrogenase to stop the conversion from ethylene glycol to the other toxic metabolites. So I was reading a little bit more about trying to understand when you would see like the high osmolar gap versus like high anion gap with ethylene glycol toxicity. And I think what I was reading is that sometimes you can see a high osmolar gap with a normal anion gap kind of early on in the phase. And then later on, when it's converted into more of its toxic metabolites, you can have a normal osmolar gap and a high anion gap. So you can't necessarily always use you can't if you have a normal osmolar gap, you can't rule out ethylene glycol poisoning based on that.
Wow. Thank you so much, Gurley. That is just fantastic learning. We have a few minutes here, and I think that this is actually a really right case to do a bit of a cognitive autopsy for ourselves on in terms of thinking through the case. And I'm just curious if anybody out there would be comfortable unmuting and sort of sharing now that you know the final diagnosis in this case, as you look back through how we reasoned through the case, are there things that we maybe could have thought about differently as we moved forward? Feel free to unmute yourself or again, share things in the chat.
I'll put myself on the spot first because I did not trust the osmolar gap, even though this was wide. I was misled by the fact that her toxic alcohol levels were undetectable without knowing the caveat of ethylene glycol being a really sneaky one. And it's just the fact of having a level that, seals the diagnosis. So that's the big lesson for me on this one.
Thank you so much for sharing that, Xavier. I will say, as I look back, I think for me, it really is understanding the nuances of the differences between both what an osm gap tells us, but also what things may be missed by it. The same thing goes for the volatile alcohol panel. Like, there is conceptually understanding what the name of a test means, but then there's the second layer of actually knowing what it does and does not test for. And for me, I made the cognitive gap of like, oh, volatile alcohols, exactly as you mentioned, Lorraine, like volatile alcohols, ethylene glycol must be on there. And so we can sort of cross that off the list. And I've done something similar with other things, right? Trusting a therapeutic drug level test in the blood, but not understanding the pharmacokinetics of it to really realize what actually is this test result telling us. I'm curious, anybody else have sort of final thoughts on the case? For those of you who shared out loud, like Carolyn, Deb, Anne-Marie, anybody who sort of feels like there are other takeaways from this case.
One thing that I was looking at earlier in the case is, does the lactic acid fully explain the anion gap? Is something to think about, because the anion gap was 32, and if we said a normal is 12, then does the lactic acid really fully explain it? And if not, then thinking about other things we need to be looking for.
Love that teaching for Anne-Marie. Thank you. Well, fantastic. Well, I'm going to turn it over now to Gabrielle to take us through some of the teaching points from this case. But I just want to say thank you to everybody who contributed in the chat. Thank you to everybody who shared out loud. This was a really challenging case, and I think that's certainly a whiteboard that I'm going to have to go back and look at multiple times to extract all of the learning from it. But Gurleen, as always, thank you for bringing such fantastic learning. I want to thank everybody who shared their thoughts out loud and in the chat. Rebecca, Ravi, Carolyn, Deb, Anne-Marie, Motaz, Xavier, just really brilliant contributions from everybody. This was a ton of fun and a ton of learning. And yeah, Gabrielle, take us away. Oh, and Rafa, thank you for heroic efforts scribing for a lot of clinical data to work through the case. We appreciate you a ton. But now I'll turn it over to Gabrielle for the final teaching points to take us home.
Thank you so much, Jack, for the opportunity. Such an amazing case, Caroline. Thank you so much. I have learned a lot, and I also didn't know the caveat of the ethylene glycol. So to start with the teaching points, first, we were approaching the hyperacute nature of altered mental status. And we were thinking about the mnemonic MIST. So this stands for metabolic, infection, structural, and toxins causes. We have to study and inquire who is our patient. For example, an older age can predispose to vascular etiologies. We also want to think about what's the medication the patient is using or was using, the immune status, the past medical history that can predispose to certain metabolic conditions, and also the context in which the altered mental status happened. If there was any trauma history, any seizure. Later, with the history of present illness and the physical exam, we were dissecting this mnemonic. For example, in the metabolic group, the Kussmaul respiration plus the diabetes mellitus past medical history, we were thinking if this could be a hyperglycemic complication such as DKA, or if this could be a hypoglycemia with certain infection or metformin associated lactic acidosis. So for infection, this carries a high morbidity and mortality, and still was in our differential diagnosis. So for structural, we were thinking if we could do some images to give us more clearness. And for the toxins, the patient was using antipsychotic medication, which can predispose her to neuroleptic malignant syndrome, and also the hyperacute nature. Because this was very hyperacute, we were still considering this could be a very nice hypothesis. So later in the lab workup was very important. The DKL picture, just to give some pairs, the glucose is less than 600, the bicarbonate less than 18, the anion gap has to be elevated, more than 10. In the urinalysis, we might see moderate to high ketonuria, and the serum beta hydroxybutyrate should be elevated. But also we want to be open to more hypotheses, such in this case that it was an ethylene glycol toxicity, and this could be a false positive to the high lactate. So later, with the increased lactate plus acidosis, we were thinking if this could be a metformin side effect, or if this could be an infectious condition predisposes to DKR or hyperperfusion. And also the arterial gas was compatible with an aspirin toxicity. Then we, finishing the puzzle, we have a problem representation that a patient with a rapidly progressive kidney failure plus hyperacute metabolic acidosis and respiratory alkalosis plus increased lactate. We're thinking of 3 hypotheses: the metformin toxicity, if the aspirin toxicity, and alcohol toxicity. And the final diagnosis was ethylene glycol poisoning and metformin overdose. Thank you so much, and see you tomorrow.